Good morning, everyone. Welcome to Pediatric Journals. I'm Plymouth. If you are anywhere near the Tanglewood Complex, please join us in person at the Low Mountain Conference Room. And as always, thank you for joining us virtually. Our speaker today is Dr. Alysha Taxter. She's an Associate Professor of Pediatrics at Nationwide Children's Hospital in Columbus, Ohio, in the Division of Pediatric Rheumatology and Clinical Informatics. She obtained her medical degree from Wright State and her pediatric residency at University of Minnesota. She then went on to do a pediatric sports medicine fellowship at Cincinnati Children's and a pediatric rheumatology fellowship at Children's Hospital of Philadelphia. She also has a Master's of Science in Clinical Epidemiology and Biostatistics from the University of Pennsylvania. After completing fellowship, she became interested in informatics and sought additional training. She is now an EPIC Physician Builder certified and became board certified in clinical informatics. She clearly has no time for anything else. Her expertise spans EHR integration, leveraging patient-reported data to enhance pediatric rheumatology care, and utilizing clinical informatics to refine treatment strategies for chronic pediatric conditions. She is here as part of the American College of Rheumatology Pediatric Rheumatology Visiting Professorship Program, which we have been very fortunate to be the recipients of for quite a few years now, and we hope it continues. We are excited to hear her talk, approach the general pediatric patient with concerns for rheumatic disease. Please join me in welcoming Dr. Alysha Taxter.
Thank you. It's so nice to be here. And thanks for coming in person, and thanks to all the folks online. All right, so as Vidya said, I am here as part of the Rheumatology Research Foundation visiting Pediatric Rheumatology Professorship Program. Goals of the talk today. So outline, we're going to talk about what is a rheumatologic disease. We're going to talk about arthritis and kind of big buckets you can categorize arthritis in. We're also going to talk about fevers and when you should be thinking that the fever might be from a rheumatologic condition. And then we're also going to talk about vasculitis or blood vessel inflammation and talk about some kind of buckets you can conceptualize when you think about vasculitis. So several learning objectives. So one thing is to learn the difference between arthritis and arthralgia. Another objective is to be able to create a differential diagnosis for acute as well as subacute arthritis in our pediatric patients. We also are going to talk about key features of systemic JIA and why that's different than some of the other kiddos you will see with fevers. We'll also talk about some blood vessel inflammation and the pathophysiology. And then also we're going to talk about how to recognize HSP or hemexternal purpura and some of the first-line treatments. All right, so what is a rheumatologic disease? So I usually hear this a lot. We don't know what's going on. It's called rheumatology. And you guys don't have access to that. I mean, I guess you can always Google something. But usually when folks call me, they've already called multiple other subspecialists. And they're like, we don't know what's going on. We can't quite put all the pieces of the puzzle together. And the reason that is because I used to call myself an arthritis doctor. And then I realized that rheumatology is much more than just arthritis. And so then I started calling myself an inflammation doctor. And inflammation is very, very broad word. But for me, I put it into two big categories. So you have autoinflammatory disease and you have autoimmune disease. And so autoinflammatory, to me, is the innate immune system, or the part of the immune system that you're born with isn't functioning quite right. Then you have autoimmune disease, or the adaptive part of your immune system, or the part that's making antibodies isn't quite working right. It's pumping out a bunch of antibodies, and then it causes disease. But no matter how you kind of conceptualize this, at the end of the day, you end up getting tissue damage and tissue inflammation. And folks have taken, this broad concept of what is a rheumatology disease, and it's designed this really fancy picture. I don't expect you to read it. The long story short is there's lots of different reasons why we can have inflammatory diseases, such as genetic diseases, things that you're born with. So some of the fever syndromes that I see, so like Nomet-Sinka, Muckle-Wells, FMF. You can also have things that are a combination between genetics and environment, and we really don't know exactly what the trigger is, but it can be a lot more complicated than, oh, just here's your innate immune system, and here's your autoinflammatory side, and here's your adaptive immune system, or the antibody side. All right, so now, with all that being said, we're going to talk about arthritis. Get the reference? Yeah, you're staying awake, paying attention. All right, so arthralgia versus arthritis. So arthralgia means joint pain, okay, and we see this all the time. You guys see this all the time. This is very common. So arthralgia typically is going to be non-inflammatory. You can definitely have arthritis and have some joint pain, but the majority of the time the kids come in with some type of pain without a swelling component, it's going to be arthralgia. So joint pain without swelling is arthralgia. We also see arthritis. So arthritis is inflammation of the joints. You can have pain and swelling. You might have some warmth, you might have some redness, but arthritis is much less common than arthralgia. And specifically arthritis, you should have some type of swelling or some type of inflammatory component. When we think of arthritis or joint swelling, as a rheumatologist, the duration of swelling is important. So if you call me and say, I'm in the emergency room and I have a kid that has a swollen knee, and I'll say, great, how long has it been swollen for? And you'll say, a day. And I'll say, okay, that still falls under the acute, so like the cutoff is 6 weeks. So give them some NSAIDs and call me back in 6 weeks, okay? But during that acute swelling differential, you should also be thinking about infection, like cancer, and then if it's still persisting and hasn't gone away, then you'd fall into the chronic arthritis, so the more than 6 weeks. Other things that are important when I think about arthritis are what other associated symptoms have they had. So have they recently been sick? Have they recently had a URI or gastro? Do they have any tummy symptoms? So roughly about 30% of kids with inflammatory bowel disease will have extra gut manifestations of disease. So sometimes they come in with a swollen knee and I see them first and then realize they also have oral ulcers and weight loss and bloody diarrhea and that they need to go see the tummy doctors. We can also see rashes, which can go along with a lot of rheumatologic conditions, and are you having fevers? And when you think about all these other associated symptoms, some of them are, could this have been the trigger for your arthritis? But then some of these symptoms are, you have like multi-system involvement. You don't only have your joint involvement. Maybe we should be thinking about something rheumatologic. Other things to think about are the location of the arthritis. So are they large joints, like knees, hips? Are they small joints, like your MCPs and PIPs? So MCPs and PIPs, more inflammatory, can sometimes get a DIP, but usually it's going to be these joints right here. And you can also think about the age. So we definitely do see like the oligo Js, or like the littler kids that come in, usually going to be toddlers, early elementary schoolers. That's going to present with 4 or less swollen joints. They're usually going to have like, knee and ankle, a finger. Whereas, the teenagers, they come in with polyarticular disease. So they come in with lots of swollen joints. They can't make a fist. They have a hard time writing and gripping. All right, so the key to figuring out is this acute, subacute arthritis is the timeline, right? So how long have they had joint swelling? What other factors do they have that goes along with it? Do they have a preceding illness? Especially if they have any viral symptoms or recent viral symptoms, probably going to be reactive arthritis. And then when you're doing your exam, so residents, you will all learn how to do a fantastic joint exam later on this afternoon. You want to see how many joints are involved and what joints are they. If you have micromotion tenderness, so if this is as much as I can move your elbow without you jumping off the table, I'm concerned that this is probably more so a septic arthritis. A lot of times our kids might come in and have arthritis in every single joint, and yeah, they're a little stiff, but they still walk across the room and they don't complain as much as, extreme pain where I can't ambulate, I can't do activities of daily living. Signs of chronic disease. So if they in fact have a contracture or their joints really just not moving as you would expect, they have decreased range of motion, if they have muscle atrophy, if they have limb-like discrepancies, those are all signs of chronic arthritis. So it's not uncommon for me in Ohio, we'll have kids, in the winter time, they'll go south and they'll visit their grandparents. And at that point in time, it's a warm environment. They're going swimming, you know, and they're not in long pants anymore. And then you know, grandma's like, what's wrong with Susie's knee? And oh, it's swollen. And so they thought that, oh, the trip caused the knee swelling. And then they'll come and see me and I'll say, well, you know, even though you've only seen this for a week, I can see that you have lost motion, that your thigh muscles are smaller, that your the bad leg is longer than the good leg, and the reason that happens is because you have open growth plates. You get a lot of increased blood flow to the lining of the joint that causes a synovial hypertrophy and inflammation. But then also at the same time, the increased blood flow will stimulate the growth plate and cause it to grow. So it seems backwards, but the bad leg or the arthritic leg can actually be longer than the good leg. So even in those cases, even though they've only recognized it for a week, I'll probably say, you know, this is probably a chronic arthritis because you have all these other kinds of signs of chronic disease. It is rare that we see erosions or like permanent joint damage on presentation. That's much more of an adult finding. But in a very aggressive disease or a disease that's gone untreated for a long time, sometimes we can see that. We usually don't typically check x-rays to like see how many swollen joints you have or to see what damage you have, except for in special circumstances. So as a pediatrician, you have a kiddo with this, you know, with some arthritis or, you know, some swollen joints, and you're like, what do I do? So there is, essentially, I will say this a little hand waving, no test that will diagnose arthritis. The one exception is Lyme and then acute rheumatic fever. So those are the two conditions I'm not allowed to miss as a rheumatologist. You guys see Lyme here? Yeah. Okay. So for me, if you call me and you're concerned about essentially almost any rheumatologic condition, I will always say, check a CBC with DIS, a SED rate, a CRP, a CMP, any infection testing based upon history. So especially since you live in Lyme endemic areas and you see a swollen knee, definitely check a Lyme. And then if you're not quite sure if there's an effusion, do you guys have access to musculoskeletal ultrasound here or no? Like, does your radiology team do ultrasound?
Not here, but
okay. All right.
Elsewhere.
So we have access to ultrasound. If you guys don't, you can always consider more advanced imaging or just watching and waiting and then in seeing or even like reaching out some of your other colleagues like orthopedics that might be more comfortable with joint exams to say is there an effusion there or not. If there is concern for a septic joint, they usually don't see me first. They usually are in the emergency room or orthopedics first. But if there is concern for a septic joint, so right, fevers, red streaking up from the site, significant pain, micromotion tenderness, that would be concerning for a septic joint. So if you are concerned for juvenile arthritis, you can always give NSAIDs. Okay, that's not going to interfere with the workup. If it's an acute arthritis, it will melt away. If it's chronic arthritis, it won't do much. If it's some of those other things like infection or like an oncologic condition, it's not going to interfere with any of those workups. Rule of thumb, if you call me, I'll always say naproxen 10 per kilo per dose scheduled twice a day, maximum 500 milligrams twice a day. Notice steroids is not on this list for treatment. So hopefully you've all learned that you don't give steroids unless you know what you're treating, right? So if they have anaphylaxis, if they have an asthma flare, you know what you're treating. If they have a swollen knee, you probably don't know what you're treating, and I would not recommend steroids. Similarly, on the initial workup, you notice I didn't say the ANA, rheumatoid factor, any of those other fancy arthritis tests. Those tests don't diagnose arthritis. It helps me figure out a bucket to put you in later on down the road, but if your ANA is negative, your rheumatoid factor is negative, you definitely could have arthritis or juvenile arthritis. If your ANA is positive, you know, 20% of the population has been positive ANA, and they don't have arthritis. So you do not need to check any special rheumatology labs during your first pass. We've talked a little bit about reactive arthritis. So rule of thumb is this within 4 weeks of some type of infectious event. And usually textbook answer is it some type of gastro, or so that's like your classic, you know, had salmonella, had shigella, had acute viral gastro, got a swollen knee, got better in a couple weeks. But it can essentially be any virus or any infection. So we have kids that say, oh, I had, you know, the URI, and then I had a lot of swelling in my fingers, or I had a swollen knee. But the course is usually about 4 weeks after the infection. And you can have, this is a little bit semantics, you can have reactive arthritis. You might have that infection currently or recently. Then you have post-infectious where, you know, the infection was about a month ago, and then you have developed arthritis. But the key is that the arthritis will last 6 weeks or less, and that still falls under the acute or subacute categories. Big long list. Don't expect you to see all of this, but lots of infections can cause arthritis. Post-stroke reactive arthritis is a little bit different than acute rheumatic fever. You can see additive arthritis. So I had arthritis in my wrist, and then it went to my knee, and then it went to my elbow. It was okay with responding to NSAIDs. Parvo B19 can be really, really painful. For your adolescent population, you can have gonococcus. We talked a lot about GI illnesses, and then we also talked about Lyme and some viruses. So this, have you guys seen Lyme arthritis before? Okay, great. Even though, textbook is you got bit by a tick and you get the bullseye rash, in my experience, no one ever remembers being bit by a tick and nobody has the rash. They might have some recent travel history, might have spent time outside, but you guys probably, if you're in an Lyme endemic area, you're always outside, you're going to have something somewhere that might have caused the exposure. And so when I see kids with Lyme arthritis, it's like the biggest swollen knee I've ever seen. So right knee, normal. Left knee, Lyme arthritis. And then sometimes these kids, like you can see the swelling through their pants. Like through the blue jeans, you know what knee is swollen. And it's not that the spirochete or the Borrelia actually gets inside of the joint. It's the immune system sees the germ, gets really excited, gets revved up to fight off Borrelia. The lining of the knee kind of looks like Borrelia, so when it's going to fight off the germ, it attacks the lining of the knee. So we don't recommend aspiration or sending like Lyme PCRs. Half the time we positive, half the time we're negative from the synovial fluid, but we do recommend that you need to send the testing from the blood because arthritis is a late manifestation of Lyme disease. Usually it's going to be your big joints, so knees, ankles. I've seen it in other joints before, like a hip, a wrist, an elbow, but those are much less common. And usually one, maybe two joints. If it's more than two joints, I'll pause and say, is this really Lyme? And then even though kids can have like, tons of swelling, it doesn't hurt them as much as you think that should. And they usually have, some decreased motion, but they get by and still are able to do sports and everyday activities. So Lyme arthritis, we've already talked about this. So you get the testing from the blood. So you can do the screening test, which is an ELISA, and then it will reflex the Western blot if it's positive. You need 5 out of 10 of the IgG and 2 out of 3 of the IgM. The caveat of the IgM is if they've had it for a long time, you might not still have the IgM present. And then treatment depends on how old you are. So it's either going to be amoxicillin or doxycycline. And usually about 80% of folks that have Lyme arthritis will get resolution of their arthritis after treatment, after the 28 days of treatment. But there is still that 20-ish% that doesn't respond. You can try another round of antibiotics, but what we usually do is just do a steroid injection. It melts everything away. Acute rheumatic fever. You guys know the Jones criteria, so I'm going to skip this, but this is a condition that we definitely think about when we see kids with arthritis, because this is one of the things we're not allowed to miss. All right, so now we're going to talk about JA. So juvenile arthritis is the most chronic common condition, chronic rheumatic condition of childhood. It affects about 1 in 1,000 kids, so it's a lot more common. And I will tell you, when I was a medical student, they told me, oh, the adult rheumatologist said, oh, the kids, yeah, they don't, it's really rare. You'll probably never see it. So that is not the case, and it's actually one of the most common things that we see. We talked about some of the things that you can that are common findings. So you can have a leg length discrepancy, you can have muscle atrophy, you can have joint contractures. This is not the best picture, but I can argue that this kiddo probably has a little bit of a limb length discrepancy. She's kind of cocking it out to the side, and her gown covers up pretty, but I might be able to argue there might be a little bit of an effusion in it. But this is what the kids with JA look like. They're females, they're toddlers. Sometimes the joint is warm, sometimes they're stiff, and it gets better throughout the day. So we'll hear, mornings are really hard. I have a really hard time getting in her car seat. She doesn't want to wake up. Really struggle getting to school. But then she comes home and she's great and she's running around and nothing's really bothering her. So this is important for me to know, less important for you to know, but J is actually an umbrella term, and there's 7 different subtypes of arthritis. So there's oligoarticular, which is for less swollen joints. There's polyarticular, which is 5 or more swollen joints. You can be rheumatoid factor positive, rheumatoid factor negative. You can have psoriasis that goes along with arthritis. You can have enthesitis-related arthritis. This is most similar to like the adult ankylosing spondylitis. We just use a different classification criteria and call it ERA. But specifically, you can have inflammatory bowel disease associated with arthritis, and then we can have systemic arthritis. So all these other types of arthritis is excluding systemic. You have antibodies. This is much more adaptive immune system driven. The systemic is the red-headed stepchild of JIA. So when we reclassify JIA, we'll probably call it something different. But this is like the weird one. This one you present with fevers, and you can present with lots of other symptoms that are more than just arthritis. And so things that are not juvenile arthritis, things that just suddenly happen. I suddenly had acute elbow pain. I just suddenly had acute knee pain. I heard a snap and got a swollen knee. If they have extreme pain out of proportion. It was one of my first nights on call as like a real card-carrying rheumatologist. And so we were talking about this last night, maybe a little nerve-wracking. And the emergency room called me and said, we have a teenage girl and she has knee swelling, but it hurts her so bad that she's wearing Depends because she can't get up and walk to the bathroom. Can you see her in clinic tomorrow? And I said, no, this pain is way out of proportion. Especially, she should be able to walk. We see kids with arthritis and they, might have some pain, might be a little uncomfortable, but not to the point where she can't get up and walk across the room and go to the bathroom. It turns out she had a very septic knee, and it was not me. So most of the time, so only about 25% of the time kids with JA have pain with arthritis. 75% of the time it's painless arthritis. So that's one of the reasons why kids are a little bit slower to get diagnosed, is because they're not complaining about pain. And even if they do have pain, they sometimes don't realize that they're having pain because they just think that's their normal. The polyarticular arthritis, so the kids with lots of swollen joints, sometimes they have some tenderness and some stiffness. The thing about JA, it doesn't really respond to NSAIDs. So that's why I said if you see a swollen joint, put them on NSAIDs, because it's not going to interfere with anything I'm going to do. The things that are not juvenile arthritis, so the more I do, the more I hurt. So I said, the kids with arthritis, they're stiff in the morning, and then they get better throughout the day. If kids, every time I run the mile at school, I have more knee pain, that sounds very biomechanical. That does not sound anything rheumatology. My pain is worth at the end of a busy day. That sounds very biomechanical. It does not seem inflammatory. All right. You guys are juvenile, you guys are arthritis experts. So now we're going to move on to fevers. Fevers of unknown origin. You guys see this all the time. This is like bread and butter peas. My kid had a fever. Where did it come from? So most of the time will probably be infection, but there are some rheumatology things that you should be thinking, that you could be thinking about. And so we talked about the autoinflammatory versus more antibody-driven. So usually the FUOs are more so autoinflammatory, so more innate immune system driven. But because of that, they can have abnormal blood work. So I told you, the kids with arthritis, their labs are usually normal. They can be a little bit off, but nothing, knock your socks off. The autoinflammatory conditions, or the kids that present with fevers, they can have some abnormal blood tests. So those tests that we would be looking for, so you can have elevated sed rate, elevated CRP, you can have some leukocytosis as well as thrombocytosis. So you're thinking, great, that all sounds like acute phase reactants. They all go up, okay. So what makes my conditions a little bit different? So busy slide, again, more so for reference, but lots of times your FUs are going to be infectious, and there's lots of different things that cause infection, and then you can also have non-infectious etiology. So I always tell people, if you buy a rheumatology consult, you get 2 free. And usually you get ID, Hem/Onc, and Rheum, we all end up seeing the same kiddo, and then we say, it's yours, it's yours, it's yours. And then we do a bunch of workup, and then someone finally says, okay, this kiddo's mine. But with all that being said, you can think about all these things kind of, when you're thinking of your FU workup, there's not usually one differential. There's lots of big different categories that you can be thinking about. So usually it's going to be infection, and infection, infection. And once you rule out infection, you can think of the non-infectious things, like all the things on the right-hand side of the screen here. All right, so you have an 8-year-old that comes in with fever and has a fever around the month. Usually, it's usually around dinner time, usually in the evening, sometimes the middle of the night. And he looks terrible when he has his fevers. But in the daytime, he looks awesome. He's playing. And, especially when you're on night float, these kids will get admitted and the night team will see him like, gosh, this kid looks awful. And then the day team comes in, they're like, this kid looks amazing. What do you mean you had a bad night? So, playful in the day, worse at night. His hands are swollen, sometimes a little bit of a rash. And then you see all these things on exam. So you see lymphadenopathy, you have hepatomegaly, maybe some splenomegaly, his hands and fingers are swollen. He can't really move his left ankle that good, just lots of pain, decreased motion. And then you look at his fever curve, okay? So we cut off the axis a little bit. High number is fever, low number is not fever, okay? So here we have a low number. He looks awesome. Here we have high fever, it's usually greater than, these kids are usually like 39, 40s, looks miserable. And you also notice his fever pattern. So it has a high spiking fever once a day, sometimes twice a day. That's called a quotidian fever pattern. That's like the buzzword, quotidian fever pattern. These are what his fingers look like. So he has puffiness, but then also has, you can see that these knuckles also look swollen. And he has this very, just erythematous rash. Do you guys know what this is?
Systemic GA.
Yeah. Systemic GA. So this is much more immune system, innate immune system driven. And the big thing we worry about in systemic GA is macrophage activation syndrome. So essentially, how I tell families is it's like your immune system got lit on fire and your immune system is attacking your immune system. And so that's why these kids can get really, really sick. So things that we see, so we see the quotidian fever patterns, the high spiking fever once a day, sometimes twice a day. You have the rash, you can have lymphadenopathy, you can have serositis, so like fluid around the heart, fluid around the lungs, you can have hepatosplenomegaly and arthritis. Gosh, fevers, rashes, swollen lymph nodes, big liver and spleen. That sounds like a lot of other things, right? So, so for these kids, I'm always very slow to diagnose them because there can be lots of other differentials, like cancer, like infection, that you don't want to miss. And so this is also describing everything we just talked about. So pictures of the rash. So you can, so very characteristic pictures of the rash. You can also get some colorization. So like you can get red spots at the sites where they had some trauma. So they had some itching and then they had a rash there. These are things that you can see in systemic GA. So I told you like all the other kinds of arthritis, lab tests aren't super helpful. These are the one times where it is. So these kids can be anemic. They can have low platelets. Their ferritins can be elevated. Their sed rate, much more than their CRP, can be elevated. And then other things that we can use to help diagnose would be the CMP specifically looking for some transaminitis, triglycerides, LDH, and fibrinogen. So not many kids in rheumatology keep me up at night. These are the one kids that do because they can flip into something called macrophage activation syndrome, right? So your immune system starts attacking your immune system. So these kids have, more anemia, like all their counts just drop. Their ferritin levels go up. So rule of thumb is ferritins, above 500 get my attention. So I don't use it to diagnose their anemia or figure out if they need extra iron. I see it much more as an acute phase reactant. So greater than 500 gets my attention. The one thing that's unique about MAS is their sed rate can precipitously drop. So if you see like a really sick kid and their counts look okay and their sed rate is normal and they're having a fever and they're seizing, you're like, this kid is really sick, their labs just aren't responding, right? So if you're really sick, your white count should be high, your platelets should be high, your sed rate should be high, and they're not high, be concerned for macrophage activation syndrome. So initial workup that we do for these kiddos is we keep a fever diary. The majority of these kiddos are diagnosed in-house and then we'll usually be getting routine vital signs. And we usually say hold off on treating the fever because we don't want to mask we don't want to mask the fever curve. Also, rashes are one of the characteristic features of this condition, so take pictures, put them in your EHR. It can be really helpful. We talked about the lab work. And then if you are concerned for some serositis, you can do some workup for that, whether that's an x-ray or echo. Think about other etiologies. And then rule of thumb is I'll give you at least a little bit of a shot on an NSAID to see if that's going to help. But in most of the times, it's not going to really help. I might give it to you for a day or so. And then we'll switch to some of the other arthritis medicines. So usually it's IL-1 or IL-6 inhibition. So like anakinra, canakinumab, or IL-1 inhibition, and IL-6 is tocilizumab or Actemra. All right, so then other things that are not systemic that can cause fevers. So fever syndromes. So usually these are fevers, and sometimes they get chalked up to infectious etiology, but the families will say, they didn't have a runny nose, they didn't have a cough, no one else in the house was sick. And it occurs like clockwork. So every 28 days, they can put an X on the calendar, and Timmy's going to have a fever next Tuesday. And it's annoying because I can't send the kid to school because he has a fever, but he's otherwise doing pretty well. So the most common fever syndrome that we see is PFAPA. So PFAPA, so pleuritic fevers, apis ulcers, pharyngitis, or sore throat, adenitis, and swollen lymph nodes. They'll come in, they'll get strep tested, it'll be negative, and you're like, man, I'm seeing this kid every month, and they're having negative strep tests. The fever will usually last about 3 to 5 days. And the thing about PFAPA is sometimes they have all the symptoms, but usually they might have 1 or 2 of the symptoms. There's probably some things that we end up calling PFAPA that aren't PFAPA. Usually you'll outgrow it around age 5-ish, sometime in early elementary school. And we treat PFAPA a couple of different ways. So every time you have a fever, just give them 1 dose of prednisone. It should knock the fever out. Problem with the prednisone is sometimes it can make the fevers occur more frequently. Other things you can try is colchicine, which is gout medicine, but has really good anti-inflammatory properties, and that will be medicine that they'll take every day to prevent the fevers from coming on. You can also try cimetidine, or like the acid blocker medicine. And then in recalcitrant cases, we'll send them on over to ENT and they get their tonsils taken out. Other more common in my world, probably a little less common in your world, is FMF. So those patients will have the fevers and they're just really short. Like the fever just lasts a day or two, and they have some other symptoms like belly pain, rashes, and they also might have a family history. Like, oh yeah, I had fevers and grandma had fevers, and we just have fevers in our family, so we didn't really think twice about it because we just are a fever family. And then there's lots of other fever symptoms we can think about too. Moving on to vasculitis. Right. Vasculitis or blood vessel inflammation. We characterize vasculitis by the size of the blood vessels. So you have small, medium, and big, and that's the buckets that we cluster them in when we think about both diagnostic as also thinking about treatment. And so, complicated picture, but big blood vessels like your aorta, medium and smaller blood vessels, and then you have your veins over here. So large blood vessels that we see in kids are Takaysu arteritis. The medium-sized blood vessels, which you guys probably see a lot of, is your Kawasaki disease, as well as your PAN. And then your small vessel vasculitis is going to be your HSP, and also your ANCA-associated vasculitis, which there's several different kinds, important for me to know, less important for you to know. But the problem with vasculitis is it can be a little challenging to diagnose because these kids can have fevers, they can have rashes, they can have vague symptoms, they can be hypertensive, and usually they just have like a bunch of like systems involved, and you can't put it all together. And as a rheumatologist, I'm like, yeah, you have blood vessels everywhere. So everywhere you have a blood vessel, you can have inflammation there. So it makes perfect sense that you can have, lots of different organ systems involved here. So 3 different buckets. So Takaysu is the large vessel vasculitis. What you can see on physical exam is you can hear bruits. So listen to their neck, listen to their groin. You can sometimes listen to the back of their knees, and you can hear the swooshing sound. They usually present with hypertension, so you can also have decreased pulses, so you're feeling for the radial pulse, and you're like, I don't feel it. They can also have very vague symptoms, like I'm just fatigued. I just have, a fever here and there. I have a headache. Their inflammation markers, usually their sed rate more so their CRP can be elevated, but it doesn't have to be. They can also have claudication symptoms. So I would say we have maybe a handful of kiddos with Takayasa. They're usually later to get diagnosed. Sometimes even in my clinic, we diagnose them as something else, and then they have some new manifestation and we say, oh, you have Takayasa. So it is a hard diagnosis to make. But if you are having this hypertension and you don't have a great explanation, that's one of the things and you have the sed rate and the other big symptoms that you should be thinking about Takayasu. Kawasaki disease as well as polyarteritis nodosum or your medium blood vessel vasculitises. Kawasaki's, you guys heard of crash and burn? Okay. So you guys, hopefully you guys see a lot of Kawasaki here and or MSCE, which kind of very mimics getting out of the MSCE era, but we still have, an occasional one or two here or there. So those are your medium blood vessels. And then polyarteritis nodosa, so PAN is rare. There's something called infantile PAN, which is probably somewhere on the spectrum of Kawasaki disease. But PAN we usually think of is like you got diagnosed with Kawasaki's and you just didn't respond how we thought you would, or you have some other manifestations that we wouldn't usually expect with Kawasaki disease. Like these kids can have like digital ischemia, they can have muscle involvement, they have like severe kidney involvement, which is very different than the classic, oh, you just have the blood vessel inflammation in your heart. And then small vessel vasculitis. So the most common one that we're going to see is HSP, or Hennig swollen purpura, also called IgA vasculitis. We also see ANCA vasculitis, and there's lots of other small vessel vasculitises as well. But one of the most common manifestations is they have skin involvement. So usually they see you for a rash, or they see dermatology for a rash, and then they're like, oh, this looks like vasculitis. Maybe you should think about that a little bit more. But specifically the ANCA vasculitis, so it can be like, I think 7 years old is the youngest I've ever seen ANCA vasculitis, but these are usually going to be your teenagers. And they have rhinosinuspulmonary manifestations. So they can have like the saddle nose deformity, they can have like perforated TMs, they can have hearing loss, they can have drainage from their ears, they get multiple recurrent sinus infections. They have bad asthma. I've tried everything and I can't get it under control. Sometimes their eosinophil count be extremely elevated. They have if they have a lot of pulmonary disease, they can be having hemoptysis. Some of these kids are in the ICU and that's how they get the diagnosis. And they also have renal involvement. So rhinosinuspulmonary, definitely thinking of like an ANCA vasculitis. So HSP, you can have a capillaritis or the deposition of the IgA in the affected blood vessels. And you can also hear the term leukocytoclastic vasculitis. So that's like the neutrophil infiltration causing a small vessel vasculitis. So the 4 common things you will see. So everyone will have a rash, and this is probably a little bit more on the extreme side when you're looking at this, but you can see rashes like that. It's very classic. It's going to be gravity dependent, so it's going to be, the feet and ankles, calves, more severe. Might have some on the butt, might have some on the hands, can have it on the face. You can also have rashes at sites of trauma. So, around the stock line, around the underpants line, they have a lot more rashes than in other places. So everyone has, so 3 out of 3 get a rash. 2 out of 3 will have some type of arthritis or arthralgia. 1 out of 3 will have some GI manifestations, whether that's just a little bit of tummy irritation or the intussusception that you can see. And then renal involvement is the thing that we monitor and think about the most. Peak incidence is usually going to be like your preschooler, early elementary schooler. And it's the most common vasculitis that we see. It has a seasonality of it. So some of our conditions have seasonality, and we definitely see this. And so most of the time they'll say, what causes this? And I'll say, I don't know, it's a combination between genetics and environment. It's probably some type of infectious trigger that caused our HSP. When we see kids with HSP, so rule of thumb is it will run its course in about 4 to 6 weeks. And however, it can recur. So a third of the kids it will recur, and if it does recur, it's usually within the first year. And when it does recur, they have symptoms, but they're much more milder than before. So before I had lots of rashes, now I just have a little bit of a rash. Before I had lots of joint pain and swelling, now I just have a little bit of joint pain and swelling. So that is not unexpected. Short term, you can have side effects, or you can have complications from things we are talking about. So, kids don't like their rashes, they have tummy aches, they might have some joint pain or some joint swelling. But the thing we worry about the most in the kiddos that have HSP is the renal manifestations. So that's why we recommend routine screening for renal complications. So after the diagnosis of HSP, we recommend weekly urinalysis and blood pressure checks for the first month, and then monthly for the next 6 months. In that first month, roughly 80-ish% of kids are if they're gonna have renal disease, are gonna pick it up, and then following it out for the out to the 6 months, that's we're gonna capture up to roughly 95% of kiddos that have renal disease. So these are pictures. So if you guys have not seen HSP before, this is what it looks like. So very common on the feet. Sometimes it can look more like an ulcer. You can also have it sometimes behind ears. Sometimes when we see this, especially in infants, there's something, it's probably the same thing as HSP, but it's called acute hemorrhagic edema of infancy. Sounds like a terrible name, but it's probably just HSP in the littler kiddos. But sometimes these kiddos end up getting, what's your CPS team called here? Your SAFE team, or your child advocacy team. Sometimes those teams will get involved and then say, oh no, it's just HSP. And then here you can see, lots of rashes on the butt, gravity dependent. For kiddos that are, so like for the younger kiddos, like if they're sleeping a lot, it's usually just on the back side because it's gravity dependent. Usually the rash is going to be the first symptom that you see, okay? GI manifestations, so it's very common to have belly pain. I have had a couple kiddos that had the onset of their HSP with GI manifestations, had a huge GI workup, and then had the rash. And so in those cases, it's flip-flop, but usually you'll have the rash, then you'll get tummy symptoms, and it can, most of the time it's going to be belly pain. The thing that, if it's severe belly pain, you're going to worry about is the intussusception, but you can have lots of other GI manifestations as well. And this is the purpura inside the belly, and then arthritis. So very common, very painful. You can see that this kiddo here has probably both swollen knees, and it's usually going to be your larger joints like knees and ankles. It can be wrists, fingers, but usually it's going to be your large joints. And it's an arthritis we really don't get too excited about because it's going to melt away here in a couple weeks. We talked about renal disease, so if there is renal manifestations, we definitely need to get the kidney team involved. Sometimes they just do watchful waiting. Sometimes they'll recommend a course of prednisone. Sometimes they'll call me and ask me to start other medicines. But most of the time it's going to usually be self-limited, and it's but it's the one thing we don't want to miss. So if there is concern for renal disease, we don't want it to progress to CKD. So if you call me and you say, I think I have a kiddo that has HSP, what do I do? I'm going to tell you the same labs I told you at the beginning of the slide. So CBC with this, CMP, SID rate, CRP, and urinalysis. And if there's any concern for something else that's not HSP, like another kind of vasculitis, we will ask the skin doctors to come and get a biopsy so we can actually look for the IgA deposition underneath the microscope. And specifically, some of the other things that can look like small blood vessel vasculitis would be your ANCA vasculitis. You can have hypocomplementemic vasculitis. You can also have cryoglobulinemia causing a vasculitis. So if there's concern that it doesn't quite fit the textbook picture, we'll do some extra workup. Treatment is usually supportive cares. So if you call me and say, a kiddo has HSP, I'll say, great, you can give him some NSAIDs. Naproxen, 10 per kilo per dose, scheduled twice a week. That's pretty much like rule of thumb. I will always tell you naproxen for whatever you call me for. If they are miserable, they can't walk, lots of belly pain, then we would think about a course of prednisone. For kidney disease, I usually rely on the kidney doctors to help manage this. Usually they don't give prednisone. But sometimes they will end up needing to give like pulse dose steroids if it's very severe, as well as some other immunomodulatory agents. But the one thing that we don't want to miss, we definitely leverage pediatricians to help us out with, is monitoring for kidney disease. So weekly blood pressure urinalysis for the first 4 weeks, and then monthly for the next 6 months. All right. All right, so in summary, instead of room pearls, we're going with room rubies today. All right, so you can see lots of kids that have joint pain. That is bread and butter pediatric medicine. But some of them, most of them will not have arthritis, but some of them will, okay? So arthritis means joint swelling or pain with decreased range of motion. Most common causes of acute reactive arthritis are viral illnesses, okay? And so you have a long differential on the timeline, location of joints, as well as preceding symptoms and current symptoms that are important. But you can never go wrong with some naproxen, 10 per kilo per dose, scheduled twice a day. And then if you are seeing kids with migratory arthritis, with a sore throat and infection, you can definitely be thinking about acute rheumatic fever. But you can also be thinking about some other things like systemic GA. So if you have specifically, you have that quotidian fever patterns, that high spiking fever, you should definitely be thinking about systemic GA, especially if they also have something else like the rash, they have joint swelling, they have a big liver, big spleen, but also think of other differential diagnoses. But the one thing that I will always ask for if you call me and say, I think this kid has systemic GA is lots of questions, but one of the important things I'll ask is what's their ferritin, because that will help me figure out how sick are they. We also talked a lot about vasculitis, so the size of the blood vessel and the location of the blood vessel are important, and we categorize it into 3 big buckets, so small, medium, and large. For Takayama, it's going to be your large vessel vasculitis with elevated inflammatory markers, just vague symptoms. You're, I don't know what's going on with this kid. Medium vessel vasculitis, you guys are experts at, lots of Kawasaki disease. We can also see some polyarteritis nodosum. And small vessel vasculitis, most common condition you guys are going to see is HSP, but we can see some other ones as well. Usually going to have some type of skin involvement. And then most kids don't need, when you treat HSP, most kids don't need anything other than NSAIDs. But if they're recalcitrant or just very uncomfortable, you can think about a course of steroids, and then make sure you monitor for kidney involvement. Great, so you guys are all now rheumatology experts. Thank you for having me today. What questions do you guys have? Yeah.
Is intussusception associated with IgA vasculitis a reason to treat with steroids, or if they're otherwise fine and it's resolved?
Usually when you're doing the workup, it stops the intussusception. There is some literature to say that if you give steroids, it does help. It does help with some of the GI symptoms. So I think it'd be a little bit of a judgment call if that was like their only symptom, and it was like by the time that they, got ready to do their imaging, that everything stopped. I wouldn't feel strongly about it. But if it's going to give the family reassurance that they're not going to come back and it's going to help them feel better, then I wouldn't have any problems giving prednisone for that.
I have a question about, I'm going to add your sports medicine in here.
Okay, yeah.
So I'm thinking about the football player who gets injured on the field and now has shoulder pain.
Yeah.
And then is not recovering appropriately and ultimately becomes a psoriatic arthritis diagnosis.
Mm-hmm.
If the psoriatic arthritis gets under control, do you then limit going back to play sports? Or once they're under control and pain-free, they can go back? And
yeah, great question. So in regards to sports participation, so we have this thing in rheumatology of 5 rheumatologists in a room with 7 different answers. And so back before we had good medicines, we would aggressively treat kids with physical therapy because that's all we had, right? So even though this is as much as they could move their elbow, we put them in PT and just try to get as much motion back as possible. I do not restrict kids if they have active arthritis, but I will also tell them like activity as tolerated. So if I don't want you to get hurt because you have pain and then you don't run properly and injure something else, or you don't take the hit the right way and get injured because of your pain. So activity is tolerated. So so getting back to your question, if he has active arthritis, I would say activity is tolerated. I wouldn't just because he has arthritis. But then for sure, if he is no active disease, he should definitely be playing football without any restrictions. Yes.
Do we understand why different joints are affected in different diseases?
No, we don't. That's a really great question, though. We always have families say, like, it's only like the left side, like it's her left knee, her left wrist, her left ankle. Why does only the left side of it? I'm like, I don't know. We have plenty of kids that have just right side or both sides, but that's a really great question. We don't know why some conditions affect large joints and versus medium versus small. Great question.
Got one online.
Yes.
Dr. Kreider said, we see lots of joint pain in primary care. What would be your threshold for adding ANA to labs given the false positive rate of ANAs?
Do not check the ANA. so there's 3 reasons why we check the ANA. So joint pain is not one of them. So one, if they in fact have juvenile arthritis, so persistent joint swelling in 1 or more joints lasting as 6 weeks in a child under the age of 16. We check the ANA not to diagnose arthritis, but to stratify the risk of uveitis or the risk of eye inflammation, and that will tell us how often they need to see that doctor. So if they have swelling for 6 weeks, you can check the ANA. The other reason why we check the ANA is if we're concerned for lupus. So yes, you can have fatigue and you can have joint pain in lupus, but I need to go through the diagnostic criteria for lupus to say they have cytopenias, they have one of the characteristic lupus rashes, they have hematuria, proteinuria, they have serositis, they have, so if they have other lupus manifestations that are part of the diagnostic criteria, then I would check it. And then the third reason we check it is for Raynaud's, specifically for concern for a secondary Raynaud's. So Raynaud's is your blood vessel spasms and it clamps down and it turns white, then blue, then red, and then the blood vessel relaxes. And to be diagnosed with Raynaud's, you need at least 2 out of the 3 color changes, one of which has to be white. And we see primary, which just means you don't have anything else. It can be associated with stimulant medication. So if you have any of your ADHD kiddos, they're like, look, 1 finger, just the tip turns white. You're like, yeah, that's Raynaud's. It's not a contraindication to medicines. It just, continue supportive care. But if it really bugs them, then think about something else. But then for secondary, so if I think you have lupus, if I think you have systemic sclerosis, if I think you have something else and you have Raynaud's, then I will check the ANA. The rule of thumb is we do not recommend checking the ANA because exactly like you said, 20% of the time it's going to be a benign positive, and then we're going to have to go get it checked out, and you're going to say it's nothing to worry about.
Jason, thank you for reinforcing my conviction.
Yes, absolutely. I will reinforce that all day long. I will say the ANA test keeps me in business. All right.
Thank you.